I'm going to talk about rabies, forgotten fatal disease, and the recent topics. Ever since the ancient times, people were afraid of rabies as it is a fatal disease caused by a bite by a rabid dog. It was finally in the 19th century that scientific light was shed on rabies when Pasteur established preventive method using vaccine, which is still in use now, though at that time the existence of virus was not unknown. Rabies is caused by rabies virus that belongs to genus Lyssavirus of Rhabdoviridae family, and it is a fatal zoonosis classified as Category 4 infection and Class 3 pathogen according to the Japanese infectious disease law. It is mediated by mammals or wild animals in the epidemic regions. It is transmitted by saliva of the infected animal through the bite, but there are some exceptional non-bite cases. Upon entry from the peripheral nerve ending of the bite, the virus travels in retrograde centripetally to central nervous system. It is featured with long and varied latent period, average of 4 to 13 weeks, sometimes as long as several years. Upon entry to the brain, the virus replicates in large quantity and spreads all over the body from CNS to peripheral nerve along autonomous and brain nerves. The typical symptoms include in the prodromal stage pruritus of the exposed area, anorexia, and flu-like symptoms. After 4 to 5 days later, acute neurological symptoms typical for rabies appear. For example, acute symptoms include hydrophobia, in which you cannot swallow water and food due to paralysis of laryngeal muscles. Other symptoms include acrophobia, hypersalivation, fear, hallucination, fever, and paralysis. 10 to 20% are paralysis type without evident hydrophobia, acrophobia, and hallucination. But they all show dyssynergia and systemic paralysis, and almost all die within 10 days of symptoms onset. It is difficult to clinically diagnose the disease without the definitive lab confirmation, so you have to make sure that there is an evidence of animal bite. In addition to neurological symptoms, you can see cardiovascular, respiratory, and endocrine symptoms. Globally, about 55,000 die of rabies across the world. Most of them are children of ages below 10. Mostly, they are seen in Asia and Africa, accounting for 90%, and mostly in rural areas away from major cities. The mediator animals include, in Asia and Africa, dogs, cats, and monkeys that live close to humans. In Europe and in North and South Americas, there are wild animals like bat, fox, and raccoon. Unlike other zoonoses caused by SARS coronavirus or Ebola virus, people are not afraid or not interested. However, every day, more than 100 people die of rabies across the world. So it is a neglected tropical disease, so policymakers are not paying much attention to rabies. All mammals are susceptible to rabies virus, but As a mediator to humans, dog is critical. As you can see in the map, when you have high frequency of rabies onset in many of the Asian countries, as you can see, there are dogs not on leash. Rabies virus infect all mammals and develop diseases, but that transmission is among the same species of animals. But sometimes dogs and wolves are carnivorous, and once they get infected, and when they bite other animals, the transmission occurs. Particularly, a bat is very critical, as a bat can transmit Lissa virus, which has affinity with rabies virus. It is an important species for spillover. This shows the study in South America. Rabies virus distribution has species-specific circulation, as you can see. So far, classical rabies virus that infects mammals, including dogs, cause rabies among humans. More recently, Lissa virus, a new virus with affinity to rabies virus, has been isolated from other mammals, particularly from bats. Some of them infected humans, and some were fatal. Therefore, we must pay attention to transmission to humans, as we see Lissa virus, which are neuropathogenic like rabies virus across the world. This shows the importance of bat, as it is infected by various viruses, and as it is an important animal for spillover. This shows various viruses that were isolated and registered from bat. Here we have coronavirus, including SARS, MERS, and COVID-19 that caused pandemic. We have here paramyxil virus, including Nipah and Hendra, that led to the transmission from bat to swine and cows and humans. And here are filoviruses, including Ebola, and we have rhabdovirus that includes rabies virus. These were found with high frequency. So a bat is an important animal that causes pathogenicity to humans. Across the world, particularly in developing nations, rabies is important zoonosis, but the domestic case in Japan was eradicated more than 60 years ago. We have some sporadic imported cases, but as many people travel overseas and get bitten by animals with the risk of rabies, they get inoculated, or before the travel, some people get pre-exposure prophylaxis or vaccination. So rabies is also important in Japan as a part of the travel medicine. What we can say about rabies is that it is an important zoonosis from the perspective of One Health. It is also important from the public health point of view of the developing nations, as it is a neglected tropical disease. And with the international exchange and travel, we also need to pay attention to rabies for the health control. Rabies, as a neglected tropical disease, is very important, and as you can see in the slide, it has low priority with little funding. and it has a poor control and insufficient surveillance. And because of that, there's no data to measure disease burden or cost. And this is the vicious cycle that we see. And because of this, rabies is still a disease with the large disease burden in Asia and Africa. This is about the disease burden. Globally, more than 55,000 die per annum. Fatality is almost 100%, so investing in treatment is almost meaningless. So major expense falls into the category of PEP, amounting to $124 billion per annum. Number of patients who receive PEP is more than 15 million per year. This is 3,000-fold the number of annual deaths. Most of the PEP patients are in Asia and in Africa, in developing nations. To eradicate rabies, you need measures to control animals that cause the disease in the developing nations. Particularly, the measures against dogs is important. We also need to have measures against humans once bitten. Cost-effective and efficient measures are important. From that perspective, initiatives from the perspective One Health is critical. From the perspective One Health, to eradicate rabies, following measures are needed. Particularly, we need to pay attention to control dogs in all parts of the world, as the dogs live close to humans. And once they get bitten by dogs, we need appropriate measures to control the situation, particularly in the epidemic regions. First, with regards to the drug control, first we need to establish convenient, simple, and accurate method to diagnose the infected animal. We also need measures against the stray dogs, namely roundup and elimination. Thirdly, we need to establish registration system of the drug and inoculation system. And fourthly, we need to educate veterinarians for vaccination and diagnosis. Whether or not a dog that bit the humans need to be diagnosed of rabies properly and rapidly, and the information need to be shared with the medical practitioners. Next is about the measures for humans once bitten. PEP should be thoroughly established. Post-exposure prophylaxis is critical, which includes, in the epidemic region, once bitten, the wound should be thoroughly cleansed. And then vaccination is important, particularly in the areas with the high frequency of rabies. Rapid PEP is in need. And thirdly, when you have a high level of exposure, then rabies immunoglobulin should also be given. And if you are to travel area with the risk of infection, or if you are engaged in the risky operation, then pre-exposure prophylaxis is also possible. When a dog bites, we need to know whether that particular dog is infected or not. This is the first step. Normally, veterinarian will catch the dog and observe it. If suspicious symptoms develop, it should be put to test. Brain tissue is studied to see with the fluorescent system. The tissue should be observed for the infection, This is the standard promoted and suggested by WHO and OIE. However, you need biohazard facilities, you need clinicians and practitioners and lab engineers for autopsy and testing. In developing nations where resources are limited, this is not in full practice. This shows the brain tissue diagnosis of rabies. Using fluorescent microscope, you need to identify the viral infected cells. Currently, with AMED and with the support of JICA, we have One Health approach, a project called SATREX for eradication of rabies in the Philippines. When we do not have tools or particular devices, we have established an immunochromatography utilizing method for diagnosis. When there's not enough infrastructure or devices or even in the field, you can more simply and conveniently diagnose rabies, and the accuracy is comparable to that of standard methodology. The next is the measures once you have exposure by dog. WHO has 3 categories of the degree of exposure. In case of category 1, when you are in contact of animal, or when you feed, or when you have unwounded skin licked, you don't need any particular measure. In category 2, when you have the exposed skin nipped, or if you have abrasion or bloodless scratches, then you need to clean the wound thoroughly with running water and soap, and have vaccination several times. In the most severe case with category 3, if you have 1 or more transdermal scratches or bites, or if you have saliva contamination of mucosa, or if you are having exposure to that, then again you need to clean the wound thoroughly and have inoculation several times, and furthermore you need rabies immunoglobulin to be inoculated several times. WHO recommends several vaccination regimens. Typical one is 4 or 5 times of intramuscular inoculation on days 0, 3, 7, 14, and 28. You inoculate the vaccine. In many of the Asian and African countries, to save the dosage and for immunity purpose, 4 times of inoculation is often the regimen. On days 0, 3, 7, and 28, you give 0.1 cc of the vaccine on both hands intradermally. In both cases, tissue cultured inactivated vaccine is used. If you are going to epidemic region, or if you are poor in access of medical support, then we can use the pre-exposure vaccination as a prophylaxis, again using tissue cultured vaccine. In case of category 3 exposure, then RIG should be given in an infiltrated manner to neutralize the infected virus to prevent it from entering into the nervous system. However, RIG is in shortage across the world. Only a few people can have an access to patients in need in developing nations. In the world, only 2 to 5% of the patients have an access of RNG. In Asia, only 5% or less of the patients in category 3 are given RNG. However, most of the patients, 60%, fall into category 3. However, in the Philippines, only 1/3 of those in Category 3 are given RIG, according to what we have surveyed. Once symptoms appear, including hydrophobia, it's almost impossible to save the lives. It is fatal. But so far, after exposure and after PEP, some developed the symptoms, but there were some cases that were rescued, as you can see here. But many of them recovered with severe neurological sequelae. But in 2004, in the United States, with the bad exposure, with neurological symptoms onset, in ICU with artificial hibernation, the patient was reported to recover. This is the case in 2004 in Wisconsin, United States, that recovered from rabies without PEP. A girl developed rabies 1 month after a bat bite. The doctor put her in hypothermia and strong sedatives to put her into a situation with the strong immune response expected. Several antiviral drugs were used, and according to the lumbar puncture on day 8, antibody titer increased and she was diagnosed with rabies. Later, paralysis and anesthesia improved. On day 31, she came out of ICU. On day 76, she was discharged. 5 months later, she was conscious, speech improved. However, she had the choreoathetosis and speech and ambulatory impediments. Based on this experience, Milwaukee Protocol was promoted and was tried across the world. These are some of the reports. So far, slightly less than 30 rabies cases were tried with Milwaukee Protocol. None was successful. In Japan, recently there was an imported case, and this treatment regimen was tried but ended in an unsuccessful case. As we have discussed, once symptoms appear, it's almost 100% fatal. There's no established treatment. So the question is whether or not there is any treatment available. And let me explain some of our researches. We tried favipiravir that was developed in Japan for anti-influenza treatment. And this was developed in Japan. Favipiravir was developed as a guanine residual-based derivative that forms nucleotide 5. It inhibits RNA-dependent RNA synthase in an HDPLT-dependent manner and inhibits the growth of viral nucleic acid. So far, we know that it has a broad spectrum of antiviral activity, particularly against negative strand RNA virus, including influenza virus, Ebola virus, SFTS virus, and Hunter virus. And as you know, it is also approved for the treatment of SARS-CoV-2 virus. We confirmed the inhibition of replication in vitro, and we also used infection mouse model to confirm its inhibition efficacy of onset of symptoms. And we show that favipiravir has a clear replication inhibition against the rabies virus with IC50 less than 30 micromolar, and if it is right after exposure, monotherapy of favipiravir had prevention effect. But in real practice, with effective concomitant use of vaccine, we can expect effective prevention. In reality, it can serve as an alternative for RIG, which is in real shortage. Furthermore, we prepared recombinant rabies virus incorporating luminous or fluorescent gene, whose maximum absorption ranges in the near-infrared wavelength with high transmittance from the deep body. The recombinant virus was injected experimentally into mouse to establish a system to chronologically check the antiviral mechanism and activity. Virus is inoculated into the left lower limb of the mouse, and local viral proliferation was confirmed. Later, the virus enters the spinal cord and finally proliferates in the brain, leading to the onset of symptoms. Using this system that we established, with the live mouse, we can test various antiviral drugs at different stages from latency, onset, paralysis, and death. Before concluding my talk, I'd like to discuss rabies in Japan and the problems we face. Rabies did not exist in Japan in old times. Rabies was introduced during Edo period from Nagasaki, and there were chronic epidemics during Meiji to Showa eras, mostly in larger cities. Rabies Prevention Act was enacted in 1950, and thanks to high quality awareness on hygiene and insular geography, rabies was eradicated 7 years later, and the state is maintained for close to 60 years. The Rabies Prevention Act includes dog registration, mandatory vaccination, capture and elimination of stray dogs, and mandatory quarantine of dogs for import and export. The last domestic case was reported in 1956, and there were only 4 imported cases in 1970, 2006, and 2020. But there are problems on anti-rabies measures in Japan. First is the issue on import quarantine. Second is the lack of total dog registration and routine immunization. Only 50% of dogs are registered, and the rate of inoculation is only 40%. Thus, there's always a risk of re-emergence of rabies. Although rabies is preventable with PEP, no proven cure exists after the onset of symptoms. This is the message I'd like to conclude my talk with. Thank you very much.